This is an overview of the infant well-child exams that are going to occur in the first 12 months of life. A special thank you to former colleagues and current colleagues Dr. Lee Small and Diana Jacobson for the contributions they made to developing some of this material in the past. So remember that the physical development changes a lot in that first year of life. The immune system really begins to mature. The antigen-antibody response is actually present by 2 months of age, but the timing of immunizations is critically important because some of those maternal antigens are still present in the bloodstream. And a good example of that is we can't give the MMR before the first birthday because of the circulating maternal antigens interfering with the immune response to that immunization. So that's critically important for the timing of that MMR. Newborn skin is really thin. There's no subcutaneous fat to protect the child from temperature, heat loss, or from pressure, or it's really friable and thin, and so a minor irritation can cause breakdown. And as the child gets older, it gets thicker, more subcutaneous fat, and more protection. Central nervous system also matures profoundly in that first 12 months. The head's not held at midline in the newborn, and that develops over that first 12 months. The arms have really random movements in a newborn, and they become more symmetrical. Hands are held in fists with the thumbs inside in a newborn, and that gradually improves as the child ages, and then the moro reflex is present and becomes less intense as the child moves through that first year of life. Remember, for the HEENT exam, we're going to look at the head, we're going to look at the anterior and the posterior fontanelle and feel those suture lines. They can actually be overlapping in the newborn baby, and they should, that molding that occurs as the head goes through the birth canal should get better in the first couple months of life, but you want to do careful palpation of anterior and posterior fontanelle and document the size of those. The eyes are going to mature during this first year of life as well, and we'll talk some more about that. The ears, you're really going to look for position and alignment with the eyes, and their little nose, their obligate nasal breathers, and so their nose needs to be patent. And we're also going to look in the throat and the posterior pharynx for any abnormalities. The respiratory rate is faster, and the mucus in the respiratory tract has less phagocytic activity, so the child is not capable of fighting off infections like they will later. So it improves in the first year of life, but these children, even with a minor respiratory illness, can become critically ill, and so they should be seen. Cardiac, the heart rate is faster and the blood pressure is lower, and you really want to assess how the child is eating and growing, because those are chief signs of cardiac problems. Heart murmurs are common, and you should take the blood pressure in all 4 extremities to make sure that you're ruling out things like coarctation of the aorta. GI development occurs really rapidly in this first year of life too. The tongue thrust is still present, and so parents need to know that when they do start solids at 4 to 6 months, the child is going to stick their tongue out and make a mess, just like this picture depicts. They begin drooling, and the taste buds are developing by about 3 months of age, so parents have lots of questions about teething when that drooling happens, and in reality it's just that they don't have a very coordinated swallow. The stomach can hold 4 to 6 ounces, and empties every 3 to 4 hours. And that, as the child grows, the volume capacity of the stomach increases, and therefore feedings can become less frequent. The enzymes for digestion are not present until 4 to 6 months, and so it's critically important that families understand that they should not introduce solids prior to that time. The first year of life, we schedule well child visits in that first week of life, at 1 month, 2 months, 4, 6, 9, and 12. And those are your routine well child visits for the infant. Now, what are these components of the well child exam? We're going to start with a history of the pregnancy, birth history, family medical history, and past medical history. And then you want an interim history at every visit after that. And that should consist of the nutrition, elimination, both number of wet diapers and stools, what they look like, and how the child is sleeping, if the mom can sleep while the child is sleeping, and of course any concerns or illnesses. We also are going to do the physical examination, and you did that, reviewed that head-to-toe infant exam. And then the growth and development screen, and you've already done that in a previous module. But close attention to gross motor, fine motor, language, cognitive, emotional, and social development. And then we're going to pay close attention to any areas that are a red flag and make a decision about reassessing or referral for further evaluation and treatment. We also are going to remember the developmental theorists that inform the well child care, and we'll start with Piaget. So in this birth to 2-year age group, Piaget referred to it as the sensory motor stage. There's the reflexive stage, that's birth to 1 month, where it's basically your newborn reflexes. Then there's the primary circular stage, which happens 4 to 8 months, and there's repetition of certain behaviors, anticipating certain responses. And then the secondary circular stage is from 8 to 12 months, and that's where a child actually does directed behaviors, begins to develop object permanence, and really has goal-directed behaviors. Does a behavior anticipating response from the caregiver. And then the tertiary circular stage is 12 to 18 months, and that's where they begin to understand causality, and object permanence can actually go through several steps anticipating that, for example, peekaboo, and dropping an object and having the caregiver retrieve it and give it back to the child. So the reflexive stage, there's the infant grasp, there's the suckling reflex, there's the rooting reflex, and all of those should be present in your newborn. So that primary circular stage, there's the reflexive smile and the reflexive or responsive cooing to the caregivers talking to the child. Secondary circular stage is depicted here with, they think when the ball is behind the wall that it's disappeared. They think when they cover their eyes you can't see them. The tertiary circular stage, they begin to actually do some trial and error, and they understand that even when the ball goes in the box, it's still there. So Piaget also has some important concepts that apply to interaction with the baby and reading the baby's cues. So the infant learns through sensory motor response to bodily needs, and the eye contact and a responsive smile or their irritability indicate their needs. So it's critically important that parents learn to read the baby's cues, and in the early infancy, the baby can't postpone their need. So it's good if parents can anticipate and read the early cues. So this poster depicts for parents the early cues around feeding. So when the child begins to stir, begins to open their mouth, turning their head and seeking and rooting, those are early signs that the baby needs to eat. Mid-level cues are stretching, increased physical movement, and putting the hand to the mouth. Late cues are crying, agitated body movements, fuzzing and turning red in color, and then, as you may or may not know, it makes it harder for the child to latch and attach to either the breast or the nipple when they get to this late stage of being upset. So let's move on and talk about Erikson. Erikson talks about the psychosocial development and its trust versus Freud talks about the psychoanalytic theory, and in the 0 to 12 month, the infants is the oral stage, and 8 months to 4 years is the anal stage. Kohlberg talks about moral development and really refers to the infancy as the amoral stage. The child is totally egocentric. The focus is on getting their needs met. There's no concept of moral right or wrong, and kids want to be fulfilled regardless of the moral implications. Chess and Thomas talk about the temperament and that there's 10 dimensions of temperament in children. The first one being approach withdrawal. And so they talk about the initial response to stimuli, people, situations, places, foods, toys, and procedures can be very different in individual children. Adaptability is the ease or difficulty that children have with reacting to stimuli and how that can be modified. And then persistence and attention span is the length of time they spend on certain activities with and without obstacles. Additional parts of temperament include distractibility. So the effectiveness of the variables in the external stimuli in interfering with the child's ongoing behavior. Do they see something across the room and totally forget what they were playing with? The intensity is the energy level on an activity regardless of the quality or the direction. The mood is the amount of pleasant or and friendly or unpleasant, irritable behavior displayed toward various situations. Activity is the amount of physical motion during sleep, eating, play, dressing, bathing. So the really kind of quiet child or the really, really active child. Rhythmicity is the regularity of functions such as hunger, sleep, and elimination. Sensory threshold is the amount of stimulation, things like sound, light, external environment stimulation, that's necessary to get a child to respond. And then emotional sensitivity is the presence or absence of empathy, response to teasing, displays of embarrassment, those types of responses. So fine motor development is the progression of the grasp in the infant. So at 1 month, there's non-directive swiping. At 3 to 4, there can be more directed swiping. At 4, they should be able to corral that little Cheerio against the tray of the high chair. At 4 to 5, they should have an ulnar palmar grasp. At 6 to 7 months, they should have a radial palmar grasp that's more of a 3-point grasp. At 6 to 7, they should begin to transfer that Cheerio and have a radial digital 2-point grasp. And then 9 to 10 months, they should have a formal pincer grasp. And then 9 to 10 months, they should also develop the voluntary release. So a pincer grasp to pick up the Cheerio and then be able to drop it on the tray. Gross motor, we expect the child to roll over by 4 months, to sit by 6 months, to pull to a stand by 9 months, and the average child can walk by 12 months. So in the 0 to 1 month, the receptive skills are recognizes sound with a startle, turns to the sound and looks for the source, and quiets motor activity to a sound. When the mom coos at the baby, they begin to quiet. And they prefer human speech with a high inflection. So sorry for the dads at this point, they respond better to the mom's voice. Expressive skills, they have differentiated crying. So they have one for when they're uncomfortable, they have one when they are needing to be changed or fed, and then body language for both positive and negative responses. So what are some of our developmental red flags in this infant? If we want to look at the sleep-wake cycles and their behavior. So if they have difficulty establishing a regular sleep-wake cycle, that's a red flag. If they're inconsolable, or if you have a parent who's not reading their cues, those are all red flags to do something. What are the components of the well child visit? We want to do immunizations, what's been given to date and what have the reactions been. We want to treat any abnormals and refer and provide education. We want to provide anticipatory guidance, nutrition, health, infant care, oral health, safety, and at each well child visit we want to provide a book and emphasize to the parents the importance of reading to the infant. And many of the practices you will be doing clinical participate with the Reach Out and Read program, which provides a free book to go home with a child. The immunizations you're gonna have a whole separate module on, but make sure that you know where to find the most current immunization schedule. They're published by the ACIP on an annual basis, and frequently we'll get notifications about changes even during the year. So make sure you're staying current.